Welcome sisters, myself Paramita Chatterjee, Masters in Critical Care Nursing. The heart. Today's topic is heart failure. The heart acts as a pump, sending oxygen-rich blood out to the body and oxygen-depleted blood to the lungs. To execute its duty, it must contract with sufficient power at a regular rate throughout our lives. In the average lifetime, the heart beats about 3 billion times. That's a lot of work for one muscle. Sometimes the heart get retired. That's a joke apart. The heart can lose its power and start to fail. When that happens, this condition is called heart failure. There are so many factors which are responsible for heart failure. First, we know about the cardiac output. The basic duty of the heart to generate enough cardiac output to meet the metabolic demand of the body. What are the factors responsible? Cardiac output depends on heart rate and stroke volume. And stroke volume depends on intrinsic health of cardiac muscle, preload and afterload. So, what are the factors responsible for cardiac output? Heart rate and stroke volume. And stroke volume again depends on intrinsic health of cardiac muscle, preload and afterload. Actually, let's talk about the left heart. Left heart generate cardiac output. Left heart generate cardiac output, and we have to know how many times left ventricle contracts per minute, and myocardium of the left ventricle is healthy or diseased. This is the factors. We came to know two words, preload and afterload. What is preload and what is afterload? Preload, this picture is self-explanatory. What is preload? Preload is volume of blood in ventricles at the end of diastole. Preload is volume of blood in ventricles at the end of diastole. And afterload, this is the resistance. This is the resistance on which left ventricle must work. Resistance left ventricle must overcome to circulate the blood. This is afterload. When left ventricle relax during diastole, what amount of blood is present in left ventricle? This is called end diastolic volume or preload. By the end of diastole, just before the systole, what amount of blood is present in left ventricle? কখন? At the diastole, at the end of diastole and just before the systole. This is end diastolic volume on which ventricle has to work and push out from the ventricle to the aorta. 50% of the blood push out, not total blood. So here one word is also originated, ejection fraction. What is ejection fraction? The fraction of end diastolic volume ejected per contraction of left ventricle. This is ejection fraction. So end diastolic volume is the amount of blood present in left ventricle at the end of diastole and just before the systole, on which ventricle has to work and push out the blood from the ventricle to the aorta. The fraction of end diastolic volume ejected per contraction of left ventricle is called ejection fraction. So end diastolic volume on which right ventricle has to work and left ventricle has to work. This is called preload. When ventricle is healthy, ventricle has to push blood. When ventricle is healthy, ventricle has to push blood against peripheral resistance. Right heart push blood against pulmonary vascular resistance and left ventricle push blood against systemic vascular resistance. In which resistance occur? The small divisions of artery, major arteries. Major arteries divided into the branches, and just before the capillary network, these smaller branches offer lots of resistance by musculature of arterial tree. So left ventricle has to pump blood against this resistance, and to produce enough output it must overcome resistance. So the resistance is called afterload. Arterial system offer lots of resistance by musculature of arterial tree. So left ventricle has to pump blood against this resistance, and to produce enough output it must overcome this resistance, so that this resistance against which ventricle has to generate cardiac output, this is called afterload. Here one scenario, one story. One donkey carries load and he has to overcome this path, and this is the target point. Donkey health is healthy or not, load is preload, and the path he has to overcome, this is the resistance offered by the system, this is afterload, and this is cardiac output, the target. So if the donkey is healthy and the preload is normal, afterload is normal, donkey easily complete his work, easily achieve the target, cardiac output will be normal. If we increase the preload, donkey is healthy, resistance is normal, but we increase the preload, donkey cannot perform his work. Donkey cannot perform his work. Excessive preload means excessive end diastolic volume. Excessive end diastolic volume means excess work heart has to done, excess workload has to done by heart, so heart may failure, heart get failure. So if we increase the preload, in spite of donkey's healthy condition, in spite of normal afterload, donkey cannot perform his work. So preload is an important factor for maintaining the normal cardiac output. If the preload is normal, donkey's health is healthy, but we increase the resistance, we increase the path resistance, so donkey again failure, donkey cannot complete his work, donkey cannot achieve the target, means cardiac output will be less. So this scenario results that preload, afterload, and donkey's health, which is health of myocardium, which is health of cardiac tissue, cardiac muscle, heart. These are all main factor for cardiac output and hemodynamical normal hemodynamical status. If one is get altered, if one is impaired, if one is increased or decreased, then heart will not perform its work properly. Then another scenario is if donkey walk at a rate of 70 to 80 beats per minute, donkey perform its work properly and achieve the target. If he walks at a rate of 70 to 80 beats per minute, if donkey walk too slow, less than 20 beats per minute, donkey cannot perform his work, get failure. And again, if donkey walk at a rate of more than 80 beats per minute, too fast, so rapid, also cannot complete its work properly because ventricle is so fast and filling not properly. That's why again donkey get failure, heart will going to the failure condition. So bradycardia and tachycardia both play an important role in cardiac output, maintaining cardiac output. So this scenario is clear. Afterload, preload, and increasing health of the myocardium and also bradycardia and tachycardia also play an important role for maintaining the normal cardiac output status. Heart failure, sometimes called as congestive heart failure, has become a major health problem in contrast to other cardiovascular diseases in most industrial nations and is increasing in incidence. The term heart failure does not mean the heart has failed or stopped working. It means the heart does not pump as well as it should. Definition of heart failure. Heart failure is a clinical syndrome that results from the progressive process of remodeling in which mechanical and biochemical forces alter the size, shape, functions of ventricles' ability to fill and pump enough oxygenated blood to meet the metabolic demands of the body. Two word is much more significant word. Functions of ventricles ability to fill and pump enough oxygenated blood. Functions of ventricles ability to fill, this is diastolic phase, and pump enough oxygenated blood to meet the metabolic demands of the body, this is the systolic phase. So two phase, diastolic failure and systolic failure. Progressive process of remodeling যেখানে কিনা মেকানিক্যাল অ্যান্ড বায়োকেমিক্যাল ফোর্সেস অল্টার করছে সাইজ শেপ অ্যান্ড ফাংশনস অফ ভেন্ট্রিকল, দ্যাটস ওয়াই দ্য ভেন্ট্রিকলস রিমডেলিং ইজ দ্য অ্যাকচুয়াল কজ ফর হোয়াট ability to fill and pump enough oxygenated blood. Ability to fill in diastolic phase, ventricular remodeling affect ventricular ability to fill in diastolic phase and pump enough oxygenated blood to meet the metabolic demands of the body in systolic phase, resulting the characteristics pathophysiologic changes of vasoconstriction and fluid retention. Then etiology. Risk factor: hypertension, hyperlipidemia, coronary artery disease, diabetes, family history, smoking, alcohol consumption, cardiotoxic drug, and dysrhythmia. Prolonged hypertension promotes left ventricular hypertrophy. lead to heart failure. When arteries become narrow, due to hypertension, arteries become narrow and less flexible. It's harder for blood to travel throughout your body, and this causes your heart to work harder. Prolonged hypertension leads to narrow artery and less flexible artery, and narrow less flexible artery it makes harder for blood to travel throughout your body. And last of all, what happened, the heart has to work hard to overcome this harder situation. Over time, a higher workload leads to an enlarged heart, and to deal with increased demand, the heart muscle thickens larger. The larger the heart becomes, the harder it works to meet your body's demand. And when the heart gets harder and thickens, these enlarged heart are called ventricular hypertrophy. And ventricular hypertrophy is the much more worst condition for dysfunctional of the heart. It makes the heart dysfunctional. Then hyperlipidemia. With high cholesterol, you can develop fatty deposits in your blood vessels. Eventually, these deposits grow and making it difficult for enough blood to flow through your artery. Same scenario. If any clot plug into your artery, the arteries get narrow, then less flexible, then it make more harder for heart, and it's increase the workload of heart. If heart work harder than normal, it becomes thickens and larger, and ventricular hypertrophy last of all. And ventricular hypertrophy is the worst scenario, and it is the main cause of heart failure. Then coronary artery disease limits blood flow in your coronary artery disease, which deliver blood to your heart muscle. If heart muscle does not get blood, then heart muscle work properly? No, heart muscle not get properly, it's become injured, it's become ischemic, it's become infected. So it leads to the heart failure. Then diabetes. High blood glucose level prolonged time, if high blood glucose level from your blood, it damage your blood vessels and also the nerves that can control these nerves control the heart vessels. This damage lead to, if nerves get damaged, which nerves control the heart blood vessels, so this damage lead to heart problem or heart disease. Then family history. A family history could increase your risk of developing heart disease. You could have inherited genes that cause your heart disease. Parental history makes much more important risk factor for heart disease. Smoking. The chemicals you inhale when you smoke cause damage to your heart. How? When you smoke, it narrow your coronary artery, and it's a risk factor for developing atherosclerosis or plaque in your artery. So if the artery get narrow, then what happen? Artery get narrow and harder, heart has to work hard to work with harder artery, so heart get hypertrophied, and hypertrophied ventricle becomes a worst condition or at last it become dysfunctional and die early. So these are all damage the artery, damage the blood vessels, and increase the workload of the heart, make the heart hypertrophied and dysfunctional. Then alcohol consumption. Excessive alcohol intake can lead to a high blood pressure, heart failure. Excessive drinking can also contribute to cardiomyopathy, a disorder that affects the heart muscle. If muscles get affected, then it's the only cause of heart failure. Diseased muscle Previously I have said the intrinsic health of cardiac muscle, intrinsic health of heart, which play a important factor in a cardiac failure. So if muscles get injured, then heart get injured. Then cardiotoxic drug, chemotherapeutic agents, that is alkylating agents such as cyclophosphamide, cisplatin, damage your heart. Dysrhythmia, altered electrical stimulation impairs myocardial contraction, decreases overall efficiency of myocardial function. Dysrhythmia leads to the ability to feel properly, ability of the left ventricle to feel properly during diastolic phase. If does not get proper blood in filling time, then what happen? It's become a worst condition. Cardiac output will be less. So these are all risk factor. Then other causes: acute myocardial infarction, pulmonary embolism, thyrotoxicosis, hypertension, and hypertensive crisis, rupture of papillary muscle, VSD, and myocarditis. Acute myocardial infarction. Myocardial infarction causes heart muscle necrosis and the death of myocardial cell and a loss of contractility. The extent of the infarction correlates with the severity of heart failure. Then pulmonary embolism. Pulmonary embolism leads to pulmonary hypertension. Pulmonary hypertension leads to increased afterload. How? Previously I have already said, if right ventricle work against pulmonary artery resistance and left ventricle work against systemic resistance. So if pulmonary arteries belt pressure is increased, then right ventricle has to work against higher. The workload of the right ventricles is increased. That leads to hypertrophy of myocardial muscle fiber. This condition, if sustained, if pulmonary hypertension sustains due to pulmonary embolism, eventually it leads to change that impair heart ability to feel properly during diastole, and it becomes hypertrophy and last of all going to the failure condition. Then thyrotoxicosis. Thyrotoxicosis increases the sympathetic nervous system stimulation. If sympathetic nervous system is stimulated, then catecholamines release and vasoconstrictions happened. Hypertensive crisis. Sudden or severe increased blood pressure 180 by 120 mm of Hg. This added blood pressure, this more blood pressure create pressure or stress on your heart, and that could lead to heart failure. Rupture of papillary muscle. Papillary muscle dysfunction leads to regurgitation of blood. Papillary muscle holds the valve and valves maintain the one-way pathway for blood. If papillary muscles rupture, then heart valve not work properly, then the pathway, one-way pathway become impaired. Valve does not maintaining this one-way pathway. So what happened? The regurgitation of blood, backflow of blood. If backflow of blood is happen, that can lead to left or right-sided heart failure. Then VSD, ventricular septal defect. This is a congenital heart disease. I will discuss in later. And myocarditis. Myocarditis damages your heart. If your heart muscle is damaged, so that it cannot pump the blood as well as is done before. Then chronic cause: coronary artery disease, hypertension, congenital heart disease, cor pulmonale, cardiomyopathy, anemia, bacterial endocarditis, and valvular disorder. Cor pulmonale. Cor pulmonale is a condition that causes the right-sided heart failure. Why? Previously I have said cor pulmonale means increased pressure in pulmonary belt. Pulmonary hypertension is present, and due to overcome this pressure, this hypertension, pulmonary hypertension, right-sided heart has to workload. If if right-sided heart workload is increased, it leads to hypertrophy of myocardial muscle fiber. And sustained hypertension in cor pulmonale eventually leads to damage or impair the heart's ability, and it makes the heart failure. Then cardiomyopathy. Cardiomyopathy, when the heart muscle weak or stiff, it's unable to relax, or it had two failures, systolic failure or diastolic failure. If muscles are unable to relax or if muscles are too much stiff, then heart muscle causes heart failure. Blood, not cardiac output is going properly, and not the left ventricle or right ventricle able to fill properly. In diastolic phase, the right ventricle and left ventricle not fill properly, and in systolic phase it cannot eject the blood out from the left ventricle to the aorta properly. Cardiac output will be less if muscle is diseased condition. Then anemia. Anemia can cause stress on the heart and kidney, and that can lead to damage to both organs and health problem. Bacterial endocarditis. What is bacterial endocarditis or valvular disorder? The inner lining of your heart and surface of its valves is called endocardium. If germs or bacteria from other parts, especially mouth of your body, spread your blood and attach to this lining, it causes endocarditis. And if it left untreated, endocarditis can cause arrhythmia, valve damage, and congenital heart failure. Last of all, heart gets failure. Precipitating causes: anemia, infection, thyrotoxicosis, hypothyroidism, dysrhythmia, bacterial endocarditis, and pulmonary disease, Paget's disease, nutritional deficiency, and hypervolemia. Most of them are discussed previously, completed. Then new one is nutritional deficiency. Certain micronutrients, thiamine, selenium, niacin, taurine, in the myocardium tissues have already been associated with alterations in myocardial energy production and calcium balance, oxidative defense. So these pathological changes may lead to myocardial remodeling. If myocardial remodeling is present, then it leads to heart failure. This is the important role played in heart failure, nutritional deficiency. Then another new one is Paget's disease. Paget's disease affects a large amount of bone tissue. The heart pumps faster and harder in order to supply blood to extra bone as well as all tissues of the body. If the heart cannot pump properly, then heart failure develops. Pulmonary disease. Pulmonary disease is confusing with cor pulmonale. Cor pulmonale and pulmonary disease are confusing word. This is same as pulmonary hypertension and cor pulmonale, how affects the right ventricle. Then comes to dysrhythmia. Dysrhythmia, if it is an abnormal or irregular heartbeat, if you have a dysrhythmia, your heart might beat too fast or too slow. If heart beat fast, too fast and too slow, the heart failure may be occur. How? If too fast heartbeat is present, then left ventricle or right ventricle not able to feel properly during diastolic phase. If too slow beat is present, then contraction will not properly or cardiac output will be the less. So heart failure and dysrhythmia often occur together or one after another. This is because dysrhythmia and heart failure are related to one another. It is happen one after another. This is because a failing heart muscle can affect the heart rhythm. And on other hand, if body spaced rhythm is abnormal, it can also tax a hard working heart muscle. So this is interrelated condition. Related terms: cardiac output, volume of blood ejected out from each ventricle per minute. Volume of blood ejected out from each ventricle per minute, it is about 5 to 6 liter per minute. And stroke volume, same, volume of blood ejected per ventricle but per beat, it is volume of blood ejected out from each ventricle per minute, and this is volume of blood ejected per ventricle per beat. It is about 5 to 6 liter per minute. It is about 70 to 80 ml per beat. Cardiac output, stroke volume into the heart rate. Ejection fraction. Previously I have already said the fraction of blood, which blood? The end diastolic blood which is ejected from the ventricle out of the ventricle to the systemic circulation or pulmonary circulation. So this is ejection fraction. What it is? Percentage of blood ejected from the ventricle out of the end diastolic volume. This is ejection fraction. Normal ejection fraction 65%. Preload and afterload. Amount of sarcomere stretch experienced by cardiomyocytes at the end of ventricular filling during diastole. Amount of sarcomere stretch experienced by cardiomyocytes at the end of ventricular filling during diastole. And afterload, the pressure that the heart must work against to eject blood during systole. This is the end diastolic volume by which the sarcomere stretch, and this amount of sarcomere stretch experienced by cardiomyocyte when at the end of ventricular filling during diastole, at the end diastole. And afterload, this is the resistance that the heart must overcome during its work time. For what? To eject the blood during systole. Preload is during diastole and afterload is during systole. Amount of sarcomere stretch due to the presence of end diastolic volume of blood which experienced by the cardiomyocytes, this is preload. And this is the resistance, that resistance must overcome by the left ventricle and the right ventricle to eject blood, which time? During systole. This is the anatomical structure of heart. Now we have to know what are the pathophysiology behind for heart failure. Myocardial dysfunction. Myocardial dysfunction, if ischemic heart disease present, hyperthyroidism present, myocardial infarction present, valve disease present, hypertension present, alcohol present, these are all risk factors. These risk factor leads to myocardial dysfunction. These risk factor leads to myocardial dysfunction. And myocardial dysfunction is, if present, that leads to decreased cardiac output, decreased blood pressure and decreased perfusion to kidney. And if that scenario is present in heart, decreased cardiac output, decreased blood pressure and decreased kidney perfusion, then first compensatory mechanism activated. Heart tries to compensate this condition. First compensatory mechanism, activation of baroreceptor. If baroreceptor activated, which is present on the aortic arch and carotid sinus, stimulation of vasomotor regulatory centers in medulla, activation of sympathetic nervous system. If baroreceptor activated, then sympathetic nervous system get activated. If sympathetic nervous system activation happened, then it release catecholamines. What are the catecholamines? Epinephrine and norepinephrine. Norepinephrine and epinephrine, the action of catecholamines is vasoconstriction. If vasoconstriction happen, then what will be happen? If blood vessels get constricted, then afterload increase, means resistance increase. If blood vessels narrow or constricted, then resistance will be increased, afterload will be increased, blood pressure will be increased, heart rate will be increased. This is one compensatory mechanism. And another compensatory mechanism is activation of renin, angiotensin, aldosterone system. If perfusion to the kidney is impaired, then kidneys secrete renin. And then renin converts angiotensinogen, which is present in the liver, as serum globulin, which is produced in the liver. Renin converts angiotensinogen to angiotensin 1. Angiotensin 1, which then circulates in the lungs. And angiotensin converting enzyme in the lumen of pulmonary blood vessels converts angiotensin 1 to angiotensin 2. And this is potent vasoconstrictor. Catecholamines acts as a vasoconstrictor. Angiotensin 2 also acts as a potent vasoconstrictor. It again constricts the blood vessels, and which leads to increased afterload, increased blood pressure and increased heart rate. Angiotensin not only constricts the blood vessels, it also stimulates the secretion of aldosterone from the adrenal cortex. Release of aldosterone, what happens? If aldosterone is released from the adrenal cortex, it also leads to sodium retention. And if sodium retention present, then sodium invite much more water. If much more water accumulate in the heart, then blood volume increase. If blood volume increase, then fluid volume overload will be present. If fluid volume overload will be present, then heart workload is increased. If fluid volume workload is present, then what will happen? Preload increased. If preload increased and afterload already increased, preload increased due to aldosterone. Aldosterone invites sodium, sodium invite water, and water accumulate in the heart. So preload increased. Preload means end diastolic volume, and it stress the myocardial fiber. And also afterload increase due to vasoconstriction. If afterload increase, preload increase, then heart will work harder. Heart will work harder because preload increased, it results in diastolic blood volume in ventricle increased, stretching of myocardial muscle fiber, then increased size of ventricle. If ventricle size is increased, for what? Compensatory mechanism tries to compensate increased workload. So heart get hypertrophied, ventricular hypertrophy present. This ventricular hypertrophy is called ventricular remodeling. Ventricular remodeling is hypertrophy results abnormal changes in the structure and function of myocardial cell. This process is called ventricular remodeling, and this is the last stage. Enlarged myocardial cell become dysfunctional and die easily. So, what are the pathophysiological changes in systolic failure? Here, first one is poor contractility of myocardium. Contractility failure. Poor contractility of myocardium. That leads to decreased cardiac output, that decreased ejection fraction, that leads to systolic heart failure. If poor contractility of myocardium is present, if myocardial intrinsic health is damaged, first one factor, intrinsic health of myocardium is damaged, then cardiac output will be decreased. If cardiac output is decreased, ejection fraction will be decreased, then systolic heart failure. And which one? Diastolic failure. If stiff myocardium is stiff, then impairs the ability of the left ventricle to fill up the blood. If left ventricle cannot fill properly, then what will happen? Here pressure will be increased. Pressure will be increased in left ventricle, and also the pressure will be increased in left atrium, and also pressure will be increased in pulmonary vasculature, then pulmonary congestion, pulmonary hypertension, and last of all decreased stroke volume, decreased cardiac output. If one door is closed, means left ventricle is filled up with blood, door is closed, blood cannot come from left atrium to left ventricle, left atrium also filled with blood, door is closed, blood cannot come from pulmonary vein to left atrium, pulmonary vein also filled with blood, increased pressure, this fluid distributed to alveoli, whole the pulmonary vasculature get filled with blood and pressure increased, then pulmonary hypertension. This is the first pathophysiological changes in diastolic failure. So, pulmonary bed is affected in diastolic heart failure. In right ventricle, pulmonary hypertension present, decreased right ventricular emptying, decreased left ventricular filling pressure, and rapid cardiac damage. Mixed systolic or diastolic failure, dilated cardiomyopathy, decreased pulmonary pressure, dilated and poor filling and emptying of both ventricles, biventricular failure. Left-sided and right-sided heart failure already discussed. Then acute failure or chronic failure. Sudden onset of symptoms such as acute pulmonary edema. This is acute failure. And chronic failure, this is long-term process. This is long-term process accompanying with compensatory mechanism. This compensatory mechanism can progress to acute phase in the setting of dysrhythmia or ischemia or sudden illness. This is sudden onset, this is long-term process. This is actually acute pulmonary edema, and this is the long-term process accompanying with compensatory mechanism, and it progresses to the dysrhythmia and ischemia. This is a chronic failure. Then compensatory mechanism. I have already said during the pathophysiological changes of the heart. And this is the first one is sympathetic nervous system activation. Second one is neurohormonal mechanism, renin, angiotensin, aldosterone system, and last one is the hypertrophy. Again, I told you what is sympathetic nervous system activation. This is the first mechanism triggered in low cardiac output states, and it is least effective. What happened in sympathetic nervous system activation? When cardiac output is decreased, body tries to compensate, it stimulates the sympathetic nervous system. When the sympathetic nervous system activated, catecholamine released. When the catecholamine is released, catecholamine main action is vasoconstriction. It constricts the blood vessels, and cardiac output will increased, and blood pressure will increased, afterload will be increased, and it also shunt blood from non-vital organ to vital organs. That's why in failure condition we have seen the pale skin, cold and clammy skin, because blood shunted out from skin to the kidney, heart muscle. So shunting of blood from non-vital to vital organs. This is the sympathetic nervous system activation. Mainly vasoconstriction done by catecholamines. When the vasoconstriction is present, then cardiac output will be increased. Then neurohormonal mechanism, renin, angiotensin, aldosterone system, which is also called RAAS. Decreased cardiac output resulting from decreased blood flow to the kidney. If perfusion of the kidney is damaged, that is sensed by juxtaglomerulus apparatus, kidney secrete renin. This renin converts angiotensinogen, which is present in the liver, to angiotensin 1, and angiotensin 1 convert to angiotensin 2 with the help of converting enzymes from the lungs. These angiotensin 2 are potent vasoconstrictor. This constrict the blood vessels, resulting increased BP, and also it released aldosterone from the adrenal cortex. And aldosterone invites sodium, sodium invite water. That's why water retention happen. More water accumulate in the heart. That's why volume is increased, blood pressure will be increased. Another one is hypertrophy, which is compensatory mechanism of the heart. Last one. When the heart workload is increased, why the heart workload increased? Because preload increased, afterload increased. Why preload increased? Blood volume increased. Why blood volume increased? Because blood volume increased due to secretion of aldosterone. Aldosterone invites sodium, sodium invites water, so end-diastolic volume increased. If end-diastolic volume is increased, then preload will be increased, and also afterload increase. How afterload increase? Due to the sympathetic nervous system stimulation. This is obviously angiotensin 2 helps in vasoconstriction. That's all increase the afterload by constrict the blood vessels. So heart has to work against the increased preload, increased afterload. And what happen in the heart? If heart workload is increased, then stretching of myocardial muscle fiber and size of the ventricles also increased. So heart tries to compensate for increased workload, and that thickens the heart muscle, and that leads to ventricular hypertrophy. When ventricular hypertrophy is present, hypertrophy results abnormal changes in structure and function of myocyte cell. This process is called ventricular remodeling. Hypertrophy of the heart results abnormal changes in the heart and function of myocyte cell. This process is called ventricular remodeling. What changes? Change of round bowl shape of the heart as a result of compensation. এত compensation করেছে, increased preload, increased afterload, এত কিছু সময় compensation করতে করতে লাস্টে হার্টের স্ট্রাকচার অ্যান্ড ফাংশন চেঞ্জ হয়ে যাচ্ছে. And this phase is called ventricular remodeling. Here one factor play an important role, Frank-Starling law. Which is Frank-Starling law? The degree of stretch is directly related to the force of the contraction. The degree of stretch is directly related to the force of the contraction. One word is degree of stretch. What is degree of stretch? The degree of stretch related to the myocardial fiber stretching, where is actin and myosin is present. Why myocardial fiber will be stretched? Due to the presence of excess end-diastolic volume. If end-diastolic volume is present, if heart workload is increased, then stretching of muscle fibers is also increased. This stretching, the degree of stretch is related to the force of contraction. মানে তুমি যদি একটা ইলাস্টিক গার্ডারকে ফার্স্টে টানতে থাকো, সে যত তাড়াতাড়ি আগের পর্যায়ে আসবে, প্রথমবার টানলে, দ্বিতীয়বার টানলে তত তাড়াতাড়ি আসবে না, থার্ড টাইম টানলে আরও দেরি করে আসবে, ফোর্থ টাইম টানলে আস্তে আস্তে লুজ হতে স্টার্ট করবে, এবং লাস্ট টাইম ওটা লুজই হয়ে যাবে, আর আগের পর্যায়ে আসবে না. ঠিক সেই জিনিসটাই হার্টের ক্ষেত্রে হচ্ছে. If we stretch out the heart muscle, the heart contraction ability not doing properly as before it is doing, because this mechanism becomes the This mechanism failed the heart. Frank's Starling law, the degree of stretch of the muscle fiber becomes worsens the contraction ability of the heart. আগে যতটা ভালোভাবে হার্ট কন্ট্রাক্ট করতো, যতটা ভালো কার্ডিয়াক আউটপুট হতো, সেই পরিমাণ হার্ট কন্ট্রাকশন হবে না, কারণ হার্ট এতটা স্ট্রেচ হয়ে গেছে, মাসেল ফাইবার এতটা স্ট্রেচ হয়ে গেছে, ঠিক ইলাস্টিক গার্ডারের মতো, সে আগের অবস্থায় আর আসতে পারবে না। So eventually this mechanism becomes inadequate because the elastic elements of the muscle fibers are overstretched and can no longer contract effectively. So thereby last of all decreased cardiac output. যদি হার্ট মাসেল স্ট্রেচ হয়ে যায়, ওভারস্ট্রেচ হয়, then heart will not contract properly. If heart will not contract properly, then cardiac output will be decreased. Then counter regulatory mechanisms. Here atrial natriuretic peptide and B-type natriuretic peptide plays an important role. These are two hormones which produced by the heart muscle. These two hormones, what is the action of atrial natriuretic peptide and B-type natriuretic peptide? This promote venous and arterial vasodilation. If venous and arterial vasodilation is present, it reduces afterload and preload. If vasodilation is before that we have already said that if vasoconstriction is present, afterload increased, then opposite effect is vasodilation. If vasodilation is present, afterload reduce. So atrial natriuretic peptide and B-type natriuretic peptide, which is produced by the heart muscle, that promote venous and arterial vasodilation. If venous and arterial vasodilation happen, then reduce afterload and preload. And ANP, BNP also against the aldosterone and endothelin, which is vasoconstrictor. It acts against it. Aldosterone invites sodium, and that's why it invites water, and water accumulate, and endostolic volume increased, preload increased, heart workload increased. If aldosterone antagonist is present, then what happened? Diuresis, enhanced diuresis means excess water released from your body, then preload decreased. Clinical manifestations of left-sided heart failure. This is the forward failure. Altering the filling and pumping function of left ventricle, congestion occurs mainly in the lungs from blood backing up into pulmonary veins and capillaries. What will be happen in left ventricle failure? If left ventricle is failure, we know if left ventricle is failure, then pulmonary bed is affected. If left ventricle is failure, then pulmonary vasculature, pulmonary bed will get affected. A pulmonary problem we must feel or see. And if right ventricle get affected, then problem is accumulation of water in vital organ. So what will happen in left ventricle? Pulmonary congestion. When the left ventricle cannot actively pump blood out of the ventricle into the aorta and the systemic circulation, the increased left ventricular end diastolic blood volume, left ventricular end diastolic volume increased, and the pressure increased in the left ventricle, which decreases blood flow from the left atrium. And also pressure in the left atrium increase, and blood volume and pressure build up in the left atrium, decreasing the flow through the pulmonary vein, and pulmonary venous blood volume and pressure increase in the lungs. Left ventricle pressure increase, that's why left atrium blood cannot go to the left ventricle. Left atrium pressure increase, that's why pulmonary vein blood not go to the left atrium. Then blood accumulate in the pulmonary capillaries, pulmonary tissue and alveoli, causing pulmonary edema and impaired gaseous exchange. And due to impaired gaseous exchange, the clinical manifestation will be dyspnea, cough, crackles and low oxygen saturation. Dyspnea or shortness of breath may be precipitated by moderate activity. Dyspnea can also occur in rest. The patient may report orthopnea. Orthopnea means difficulty breathing when lying flat. Patients with orthopnea may use pillow. Some patients have sudden attacks of dyspnea at night, which is called paroxysmal nocturnal dyspnea. What is paroxysmal nocturnal dyspnea and why it will happen it at night? Fluid that accumulates in the dependent extremities, that is leg, during the daytime, this fluid reabsorbs into the circulation when the patient lies down at night. So at night time, left ventricle cannot eject increased circulating blood volume. Due to the diseased left ventricle also diseased condition and increased blood volume during night time, the left ventricle cannot eject this much blood from the circulating blood volume to the aorta. So the pressure in the pulmonary circulation increases. If impaired left ventricle cannot eject the increased circulating blood volume, then blood pressure will be high in the left ventricle, then also the left atrium, and then also the pulmonary circulation. So shifting fluid into the alveoli, and the fluid filled alveoli cannot exchange oxygen and carbon dioxide. Without sufficient oxygen, the patient experiences dyspnea and has difficulty sleeping. This is called paroxysmal nocturnal dyspnea. And another one is cough. Cough is associated with left ventricular failure, is initially dry or non-productive. Crackles may be present. Crackles auscultate throughout the lung. At this point, oxygen saturation may decrease. And fatigability. Due to decreased cardiac output, the body cannot respond to increased energy demand, and the patient becomes easily fatigued because cardiac output is less or energy requirement is high. The patient cannot withstand this condition. The patient becomes easily fatigued and has decreased activity intolerance. Insomnia, restlessness, tachycardia. Why tachycardia is happened? Tachycardia because of the catecholamines. The catecholamines is also released, and body wants to try to compensate. And if heart beats faster, more than normal, to compensate this compensatory condition, when the stroke volume is decreased, it causes sympathetic nervous system stimulation, and when the sympathetic nervous system gets stimulated, it increases the heart rate. So tachycardia is present, and when tachycardia is present, patient may complain palpitation. And ventricular gallop is the occurs just before the second heart sound. When the mitral valve opens, it allows the passive filling of the left ventricle. The S3 sound is actually produced by the large amount of blood when striking a very compliant left ventricle. And rapid filling gallop indicates ventricular diastolic overload. And another heart failure sign symptom is when the heart failure progress, decreased output from the left ventricle can leads to decreased gastrointestinal perfusion, that leads to altered digestion. If it affects the brain, when the brain perfusion decrease, it leads to dizziness or lightheadedness or confusion or restlessness. Anxiety also a sign symptom, for due to decreased oxygenation and blood flow, anxiety increased anxiety creating a vicious cycle, and dyspnea also increased. And also another sign symptom is when the sympathetic system gets stimulated, then catecholamines release, and catecholamines transfer the blood from non-important organ to important organ. That's why the skin appears pale or feels cool and clammy. Another important sign symptom, and one important sign symptom is nocturia. Why? As reduced cardiac output, catecholamines decrease the blood flow to the kidney. Oliguria present. When the cardiac output is decreased, catecholamine also decrease the blood flow to the kidney for compensatory mechanism. So urine output drops, oliguria present. When the renal perfusion drops, then renin, angiotensin, aldosterone system develop. And when the renal, angiotensin, aldosterone system stimulated, it wants to increase the blood pressure or intravascular volume. So when the patient is sleeping condition, during that time cardiac workload decreased and improving renal perfusion. When renal perfusion improved, that time patient frequent urination at night time increases. Then clinical manifestation of right-sided heart failure, which is backward failure. Altering the pumping function of right ventricle, there are signs and symptoms of elevated pressure and congestion in systemic veins and capillary. This picture is self-explanatory. What will happen in right-sided failure? When the right ventricle fails, congestion in the peripheral tissue and the viscera. This occurs because the right side of the heart cannot eject blood effectively. One factor is right side of the heart cannot eject blood to the pulmonary artery effectively and cannot accommodate all of the blood which returns from venous circulation. From the superior or inferior vena cava, what amount of venous blood is came to the right atrium, the right atrium not accommodate this blood and not properly eject the blood from right ventricle. Two abnormal situation that leads to this venous blood stay in the jugular vein. So first one, distended jugular veins, and another one, the whole fluid accumulated in the body. This is first, if dependent region of lower extremity, this is called dependent edema. If fluid accumulate in the liver, this is called hepatomegaly. If fluid accumulated in the spleen, this is called splenomegaly. If fluid accumulated in the gastrointestinal tract, this is called ascites. If fluid accumulated in the whole body, this is called anasarca. So here is the problem with accumulation of venous circulation. Venous circulation in right atrium cannot accommodate the venous circulation, venous return, which is came from superior vena cava or inferior vena cava. It cannot accommodate the proper venous return, and also the left ventricle cannot eject blood properly. So that's why the water and blood accumulated all over the body. If it accumulated in the gastrointestinal tract, it is called ascites. If liver, hepatomegaly. If spleen, splenomegaly. If jugular veins, distended jugular veins. And if whole body, that is anasarca or weight gain. If dependent region or in leg, this is dependent edema. That are all right-sided heart failure sign symptom. Edema of ankles, unexplained weight gain. Pitting edema is obvious only after retention of at least 4.5 kg of fluid. Anasarca, massive generalized body edema. What is anasarca? Massive generalized body edema. Liver congestion, upper abdominal pain. Distended jugular veins, increased central venous pressure and pulmonary hypertension. Abnormal fluid accumulation in body cavity, that is pleural space, abdominal cavity, splenomegaly. Anorexia, nausea from hepatic and visceral engorgement. Nocturia, diuresis occurs at night with supine position. Weakness. Then cardiovascular findings in both types. First one, cardiomegaly, ventricular gallop, rapid heart rate and pulsus alternans. What is pulsus alternans? This is the arterial pulse waveform. Arterial pulse waveform showing alternating strong and weak beats. Pulsus alternans results from left ventricular failure. Here we can see alternating strong beats or weak beats. These findings should prompt further investigation. Rapid heart rate. This problem in heart failure is that the heart is not pumping out enough blood each time it beats. This is called low stroke volume. To maintain your cardiac output, your heart can try to beat faster. If increased heart rate is present, then increased stroke volume, and heart will work hard to compensate this condition. So this is the rapid heart rate. And ventricular gallop, S3 occurs just after the S2 sound when the mitral valve opens, allowing passive filling of the left ventricle. And the S3 sound is actually produced by the large amount of blood striking a very compliant left ventricle. Rapid filling gallop indicates ventricular diastolic overload. And cardiomegaly, if the heart weakens as it can with heart failure, it begins to enlarge, and this forces the heart to work harder to pump blood to the rest of the body. Heart damage, certain types of heart disease can cause enlarged heart. If the muscles of heart is damaged, if the heart weakens, that can lead to heart failure. So we know about the what is heart failure, what are the factors responsible heart failure. We came through the important word preload, afterload, stroke volume, and intrinsic health of myocardial muscle, then compensatory mechanism, sympathetic nervous system stimulation, renin angiotensin aldosterone system, ventricular hypertrophy. This is the compensatory mechanism. We also know about the pathophysiological changes in heart failure, what happened, all the pathophysiological changes that leads to congestive cardiac failure. And if the congestive cardiac failure is present, then what will be the sign symptoms in left heart failure and what will be the sign symptom in the case of right heart failure. We can differentiate it. So in the next class we'll discuss about the medical management and nursing management. Thanks a lot. Thanks a million.